funneling in. The next hour we're going to talk about restless leg syndrome, and there's a move out to change the name of this to Willis-Ekbom disease. And specifically, we're going to kind of go do a review and talk about updates and treatment challenges. So, who was Willis? And Willis was a physician in England who is most credited as being the first person to describe the circle of Willis. He also was the first person to really identify the 12 cranial nerves. But in 1672, he also was credited as being the first person to describe restless leg syndrome. And his quote went, "Wherefore to some, when being in bed they betake themselves to sleep, presently in the arms and legs, leapings and contractions of tendons, and so great a restlessness and tossing of the members ensue, that the diseased are no more able to sleep than if they were in the greatest place of torture." Hey, wouldn't it be great if our electronic medical records could do that? And then things stayed pretty much the same for the next 300 years until a Swedish physician by the name of Carl Ekbom published his doctoral thesis in 1945 and entitled it Restless Legs. And so he's actually the person that restless leg syndrome, where that name came from. And he described both the paresthetic and painful forms of the disease. And later he actually established the relationships with other conditions such as pregnancy, anemia, cancer, and blood donors. So it's important to remember that restless leg syndrome is a disease of history. There's no physical findings, and very rarely are there laboratory findings. We'll talk about a couple, but it's entirely defined by history. So NIH in 2002 laid down the central criteria, and the criteria I'm sure you're all familiar with is one, there has to be an urge to move the legs, and it's usually accompanied by some form of uncomfortable or unpleasant sensation. 2, that urge has to worsen during periods of rest and inactivity. 3, the symptoms have to be improved by activities such as walking or stretching, and the improvement is sustained as long as that activity continues. And lastly, there's a circadian component, such that the symptoms are always worse in the evening or at night than they are during the day. Additional supportive criteria includes if it has a positive response to dopaminergic agents, if there are periodic limb movements of sleep or wakefulness, and if there's a positive family history. So primary idiopathic RLS is a central nervous system disorder, and it's familial in 25 to 75% of cases, but it can follow either an autosomal recessive or an autosomal dominant inheritance. And typically, those patients with familial RLS tend to have an earlier age of onset, may even start in childhood, and a slower progression of the disease. So let's look at the role of iron. Iron's been well established to have a role in RLS. And one, there's an inverse response to the severity and the serum ferritin, with worse sleep occurring in patients with lower ferritin levels. 2, there's MRI studies that demonstrate decreased iron stores in both the substantia nigra and the putamen. 3, we know that iron is an essential cofactor for the enzyme tyrosine hydroxylase. And that enzyme is responsible for converting tyrosine into dopa, or into L-dopa, I should say. 4, the study by Early demonstrated that there were lower levels of CSF ferritin, but also higher levels of CSF transferrin in patients with RLS compared to normal controls. And lastly, there's also iron deficiency adversely affects Thy1. So what is Thy1? And Thy1 is a cell adhesion molecule that plays a role in the vesicular release of all the neurotransmitters. And there's a study where they looked at pheochromocytoma cells with iron chelation, and they found a significant decrease in the expression of Thy1. And in another study where they looked at rats that were given iron deficient data, they also could demonstrate decreased Thy1 compared to controls. And then lastly, the substantia nigra in subjects with RLS tend to have about half the concentration of Thy1 as controls. So the genetics of RLS. Idiopathic RLS has about a 40 to 60% positive family history. However, even secondary RLS, that associated with neuropathy or uremia, has a 15% positive family history. And it appears to be polygenetic, and there's at least 8 loci that are involved, and probably more. Even though it's a dopaminergic related disease, just like Parkinson's disease, there's no evidence that supports any genetic link between the two. So Richard Allen and his colleagues at Johns Hopkins in May of last year actually published a paper that discussed the role of glutamate. And what they did is they examined MRI images and then recorded the glutamate activity in the thalamus. Remember, glutamate's the activating neurochemical that is responsible for wakefulness. And they looked at images of 28 people with RLS and 20 without. The RLS patients typically had symptoms of 6 to 7 nights a week, persisting for at least 6 months, and on an average had 20 involuntary movements or more a night. And the researchers then conducted 2-day sleep studies in the same individuals and measured how much rest each person was getting and compared the controls with the RLS. And they found that the higher the glutamate level in the thalamus, the less sleep the subject got. However, there was no such association in the control group that did not have RLS. So maybe glutamate also is playing a role in the symptoms of RLS and at least the lack of sleep that's generated from it. So we're going to talk about the medications, and I've kind of created a timeline here of the medications as they develop. And there's a couple things I want you to notice on this slide. Is there are only 4 drugs that are FDA approved for use in RLS, and those are in kind of the teal color: pramipexole, ropinirole, retigotine, and gabapentin and acarbol. All other drugs used in RLS are off-label usages. So the first drug in 1982 that was released was levodopa, and levodopa was actually found to be effective in about 1/5 to 1/4 of the patients, and patients tolerated it for up to 2 years. The most common side effects were on the short term was nausea, and the most common reasons for discontinuance is it lost its effectiveness or patients developed augmentation. About 60% of RLS patients that developed augmentation within 6 months. However, the discontinuance of therapy was only necessary in about 20%. So going back to the timeline, the next drug that showed up in 1988 was bromocriptine, and we're not going to really discuss it because it really isn't used anymore, but for a short period of time it was used as a treatment. The third group is the ones in red: pergolide and cabergoline. These are ergot-derived dopamine agonists, or dopamine receptor agonists. They both proved to be highly effective in use, but unfortunately, the use of them was associated with cardiac valve fibrosis and valvulopathies. As a result, pergolide was voluntarily removed from the market by its manufacturer in 2007. Cabergoline is still available, but should be reserved for those patients that there are no other medications used and the risks outweigh the benefits. And if you do use cabergoline, the patient should undergo annual echocardiograms. So back to our timeline again, and we come to the first drugs that were FDA approved. And in 1999, both pramipexole and ropinirole were introduced. Both are non-ergot-derived receptor agonists, and they act at both the D3 and the D2 receptors. And both have been well studied. There's been demonstrated efficacy in greater than 700 patients with pramipexole and greater than 1,200 patients in ropinirole. Unfortunately, most of the studies are short-term in nature, in 6 to 24 months. The most common side effects is sleepiness, and that ranged anywhere from 5 to 56%, depending on what study. Nausea, insomnia, headaches, dizziness, edema, and impulse control disorders. And we're going to come back to that one later, because that's an important one that limits the use of these medications. The discontinuance rates were around 17% during the first year, And then from years 2 through 10, the rate's fairly constant, about 9% discontinuance per year. And the main reason to discontinue these medications are one of the adverse side effects that were mentioned, or they just began losing their effectiveness, or patients developed augmentation. So let's talk about augmentation. What is augmentation? Augmentation is actually a paradoxical worsening of symptoms during the treatment using the dopaminergic drugs, such that either the symptoms start earlier in the day, or there's extension of the symptoms, so they no longer involve just the legs, they involve the arms. There's a worsening of the intensity of symptoms, and the duration of relief from treatment is shorter and may require higher doses. So if we compare these two medications, just general characteristics, they are similar in a lot of ways. Pramipexole tends to have a little bit longer before it gets its peak blood level, and its elimination half-life is 1.5 to 2 times as long as ropinirole. I think the biggest difference is pramipexole is renally excreted, where ropinirole is hepatic metabolism in the P450 system, and specifically the CYP1A2 component of that. And that becomes important at patient selection. So if you have a patient that has underlying mild renal insufficiency, you may choose to use the ropinirole. If you have a patient that, like a lot of us have, that are on multiple medications, probably a lot of those medications have P450 involvement. You may wish to avoid any conflicts with that because it's going to change the blood level of the ropinirole either up or down depending on the drug interaction. Both cause hypotension. However, the degree of hypotension tends to be about 4 times as much in ropinirole. Both can cause hallucinations. That tends to be about twice as much in pramipexole. And both cause somnolence, with the risk being about 2.5 times as much in the ropinirole group. So if we look at dosages, I included in blue the FDA-approved dosage schedule, and then the dosages that are actually tend to be used. And as a rule, the ropinirole dose is basically 4 times the pramipexole dose. So if you start with 0.125, most people are starting with the ropinirole at 0.25, but you can start at 0.5. But there needs, as you titrate up, you need to stop when you get to around 0.5 milligram of pramipexole and 2 milligrams of ropinirole and reassess what you're doing and make sure that we're not starting to get into the augmentation phase. And then the maximum dose, as noted, is FDA says 0.5 milligrams. Most people will go up to 1 milligram of the pramipexole and 4 milligrams on the ropinirole. So if we look at long-term treatment, I could not really find long-term treatment studies on ropinirole. Most of them are on pramipexole. So this is a study that Lipford and others published in 2012, where they looked at 50 patients with a median follow-up of 9.7 years. 82% remained on the medication, and 40% of them, that medication was completely effective. And 59%, it was partially effective. And the median dose at last contact was 1 milligram. And remember, that's twice the FDA's maximum dose. The dosage had been increased somewhere in the course of treatment in 88% of those patients, and 42% had developed augmentation. However, another 28% had to have an additional medication added to control symptoms. So Richard Allen and Nathan Silver published this report, and we're going to use this slide a couple times because it's got a lot of information on it. But just looking at the pramipexole, they reviewed 164 patients and did a 10-year follow-up. And somebody know how to make this, there we go. All right. So the first line is methadone, the second line is pramipexole, and the third line is pergolide. So in the pramipexole group, they found that the first rate of discontinuance was 17%. But then you see it's actually a fairly linear discontinuance rate over the next 5 years. So the discontinuance rate due to augmentation was about 7% per year. So now we're going to go back to our timeline again. And this time we're going to look at the next FDA-approved drug, rotigotine. and that came out in 2004. And rotigotine is a 24-hour patch that's used in higher doses in Parkinson's disease, but for restless leg, it's used in dosages of 1 to 3 milligrams. And it's indicated for moderate to severe RLS. It's a D2 receptor agonist, and it has a half-life of 5 to 7 hours after you remove the patch. The most common adverse side effect that limits the usage of this drug is actually the site reaction itself from the patch, and that varied from 17% to 58% of patients. Nausea and fatigue are the other adverse side effects. But in this study that was published, after 5 years, the rate of augmentation varied from 2.5 to 13% and appeared to be less than ropinirole or pramipexole. Ortel in 2011 published a long-term follow-up study on rotigotine, and this was 295 patients over 5 years. 43% remained on treatment, and 11% had discontinued because it was no longer effective. And then again, remember the site reaction is the most common side effect. 19% had to discontinue the medication because of that. But the important thing is he found that clinical significant augmentation occurred in only 13%. And if we're stuck within the FDA dosages of 1 to 3 milligrams, that rate was only 5%. Nobody really knows exactly why, but maybe it's the longer half-life that you don't get as much augmentation. And I think that's still out there to debate. But it had a discontinuance rate of only 4% due to augmentation. So Bennis, again, repeats the similar study in 2012, where he retrospectively reviewed double-blinded studies over an 18-month period. And he looked at 745 patients on rotigotine and 214 placebo patients. Clinically relevant augmentation was seen only in 12 patients, 11 of those in the rotigotine group, 1 in the placebo group, for a rate of only 1.3%. And none of the patients treated with rotigotine for up to 1.5 years had to discontinue the medication due to augmentation. And lastly, Ortel, just in April of this year, published a study. And I put this in here because there's conflicting literature concerning RLS and cardiovascular disease. And for a long time, they said that RLS was a risk factor for cardiovascular disease. And then a paper came out around a year ago that says, no, it wasn't. So I think that's still up a debate. But Ortel didn't look at that. He just actually looked at responses, or cardiovascular response. And what they did is they took 37 patients on rotigotine and 29% patients on placebo. And then he measured beat-to-beat heart rate and blood pressure assessments at baseline and again at 4 weeks. The primary outcome actually demonstrated significant decrease in the PLM-associated nocturnal systolic blood pressure elevations. But he also demonstrated that there was an overall decrease in nocturnal systolic blood pressure, in PLM-associated nocturnal diastolic blood pressures, and heart rate. So if you're looking at this study, you'd want to think that there probably is a relationship between RLS and cardiovascular disease. So I think that question is still going to be entertained. So I'm going to go back and look at the impulse control disorders. Dopamine drugs act on the nucleus accumbens, and that is your pleasure center of the brain and helps with motivation. So when they looked at 100 patients with RLS treated with dopaminergic agents and 275 patients with obstructive sleep apnea without RLS or exposure to dopamine, and another 52 patients with RLS who had never been treated with dopamine, they found there was a significant increase in impulse control disorders in those that were treated with dopamine. There was 9% compulsive shopping, 5% pathologic gambling, 11% compulsive eating, 3% hypersexuality, and 7% for punding. Now I will have to tell you, when English is your second language and you don't have a first language, I had no idea what punding was. But punding is picking at things or lining up small items and repetitively like a stereotype behavior. So the bottom line is when you add those all together, there was a 17% chance of having impulse control disorder with dopamine. So I think this is important to counsel patients. You know, the last thing you need is to have grandma go out and spend the life savings in Vegas and then come back and say, I read it on the internet that this is your fault. So, and the mean duration of treatment before the onset of the impulse control disorder was 9.5 months, and there was found to be a significant dose effect. So the higher the dose, the more likely to get impulse control disorders. So back to the timeline again. The next group we're going to talk about is the alpha-2 delta ligands. And that group includes gabapentin, pregabalin, and gabapentin anacarbal. Gabapentin anacarbal is the only medication in this group that's FDA approved. However, gabapentin itself has been used for a long time for treatment. And in clinical trials, when they compared ropinirole to gabapentin for RLS relief, both test groups experienced similar significant improvements, but the gabapentin group actually had better sleep efficiency. Unfortunately, again, almost all the studies were short-term trials. So a meta-analysis in April 2013 of 29 random controlled trials of at least 4 weeks duration demonstrated high-strength evidence demonstrating that calcium channel alpha-2 delta ligands increased the proportion of IRLS scale responders compared to a placebo at a rate of 61% versus 37%. And the main side effects that were discussed were tired or somnolence, sleepiness, and dizziness. So Richard Allen and his group again, just this year, published a paper that looked at pregabalin or Lyrica versus pramipexole. And they looked at 719 patients over 52 weeks. And they subdivided those into 4 groups. There was the pregabalin group, the high-dose pramipexole group, the low-dose pramipexole group, and placebo. At 12 weeks, they had analyzed their data. And what they found was both the pregabalin dose and the high-dose pramipexole dose had significant decrease IRLS scores. They started with an average score of 22.4, and these 2 groups were significantly improved at 10.9 and 12.9. I'd argue that placebo did pretty good, but the reality is the low-dose pramipexole dose and placebo were basically the same. And then at the bottom, they looked at GCI rating scores, and the same you see is that there was a significant improvement in the high-dose pramipexole and the pregabalin group. If you look then at 52 weeks and look at the graphs, the top graph is symptom severity, and the bottom graph is symptom improvement. Now, you look, really, I'd really be curious to know what this placebo group did, but unfortunately at 12 weeks, that placebo group was then entered back into the active group. But if they looked at just these graphs are the ones that started from time 0 and all the way through, and does not include that placebo group in there. But you notice that all of them tended to have a similar curve. There was a tendency for the pregabalin group to have less severe symptoms, or trended lower. However, you notice that the low-dose pramipexole and the high-dose actually ended up being similar by the time you got to 52 weeks. So the other things they found was if you looked at augmentation rates, high dose had the pramipexole had a 9% augmentation rate, low dose 6.6, pregabalin 1.7. Patients reporting adverse side effects, however, actually was highest in the pregabalin group. Pretty high period. You know, basically you got 80% of people on any of these things have side effects. And then the discontinuance of side effects was actually higher in the pregabalin group because of usually the somnolence or the dizziness. So we can look at this, and this actually goes through those side effects. And you can see, again, the dizziness significantly higher, almost 40% in the pregabalin group, and 8 to 9% in the pramipexole group. And they combined the 0.25 and 0.5 because they were similar side effects. And again, much more somnolence in the pregabalin group. Headaches were slightly higher in the pramipexole group. Constipation, again, much higher in the pregabalin group. Weight gain, a little higher, but both cause weight gain. This is an important one. Even though it's a small number, this is important. This was statistically significant. People on pregabalin had about 2.5 times the risk of suicidal ideations compared to pramipexole. So I put this up here because I think this is an important one, because there were 3 drugs in this class, and 2 of them are off-label. Well, it just so happens that if you look at the False Claims Act, the first real settlement was 1996, when whistleblower David Franklin filed a lawsuit against Park Davis under the False Claims Act for marketing gabapentin or Neurontin for off-label use. 2004, they finally settled that case for $430 million. And Franklin, as the whistleblower, collected $24.6 million reward. So then, along comes September 2009, Pfizer reaches a $2.3 billion settlement for off-label usage of several drugs, but Lyrica was included in that, or pregabalin. And those 6 whistleblowers got a $102 million reward. So what I'm saying here is I think it's important as we as physicians, even if we think an off-label drug is the best drug to use, I think we need to disclose that to our patients. And if we don't disclose it, we will be the next deep pocket. So I'm going to look at the narcotics. How did they do? Tranquiliter in 2013 published this study of 306 severely affected RLS patients and demonstrated a significant improvement in symptoms compared to placebo after a 12-week trial that he actually kept as an open-term trial to 1 year, treated with oxycodone and naloxone sustained release. There were no withdrawal effects. In reality, the mean dosage was pretty low, 10 to 15 milligrams twice a day, and there was no augmentation. So I'm going to go back. Remember that slide that Richard Allen had where it had methadone and pramipexole and pergolide? This is the methadone arm of that. They looked at 76 patients that were on methadone for severe RLS over 2 to 10 years. And again, 15% dropped out the first year, whether that be from constipation, somnolence, I don't know. But none of the patients dropped out over the next 10 years. So 6 months after starting methadone, the median dose was 10 milligrams. And the median dose did not increase during the first 3 years. And then over the next 4 years, there was no more than 5 milligram increase from the 6-month dose. And the median dose after 8 to 10 years on methadone was no more than 10 milligrams more than it had been at 6 months into the treatment. So there wasn't a, we think of narcotic use. This is not somebody, the chronic pain patient. There really isn't that escalation of usage that you see in those patients. So we'll get back to the Willis-Ekbom Disease Foundation. And these people, they're the ones trying to change the name of restless leg syndrome. I personally think that restless leg syndrome is a great name because I don't think we understand what the disease is. It is a syndrome, just like congestive heart failure is a syndrome. And there are probably many diseases that link to restless leg. But they developed an algorithm from a medical advisory board and published this in September of last year. And the 3 categories that they define are intermittent RLS, chronic persistent RLS, or refractory RLS. So if you look at intermittent, they define that as having enough trouble with symptoms to require treatment on an average of less than twice a week. And they feel that the treatment for that would be first non-pharmacologic therapy, or if you're going to use medication, they should be used intermittently, not continuously. And they give us levodopa, benzodiazepine, the low potency opioids. So what they consider the management as far as a non-pharmaceutical is avoidance of alcohol, caffeine, or smoking, good sleep hygiene, moderate regular exercise, avoidance of overexertion, stress, and sleep deprivation, a brief walking or motor activities such as hot baths or leg massages before bedtime. So if you have another disease process, say obstructive sleep apnea, a lot of times they'll occur together. You're best off fixing the obstructive sleep apnea first. Try to fix their sleep deprivation that way and see if their restless leg syndrome improves. So the other thing is you should look at iron status. And most labs will report ferritin levels as being abnormal at 20 micrograms per liter. For a restless leg standpoint, you need to use the cutoff at 50. And then if you're using iron replacement, you should try to get their ferritin levels above 75. They also recommended mental activities such as crossword puzzles and video games to reduce symptoms when they're bored. And I really hope my kids don't see this because I really don't want them having an excuse to do their video games. Abstinence from caffeine, and then look at your medications that you're using. All antidepressants, with the exception of one, will increase restless leg syndrome. And that one is bupropion or Wellbutrin. All the others have the potential of making it worse. In addition, look at your antiemetics, such as metoclopramide, that will affect that. And the antipsychotics will make it worse. And then sedating antihistamines will also make it worse. So the intermittent medications, what they talk about levodopa. Remember, this has a high risk of augmentation. The other thing, remember, we're doing this, we're only going to use the medication intermittently. We're not going to keep them on it, right? The problem is it has an onset of action that's 1.5 to 2 hours before it's useful. So you better be thinking that you might get restless leg on that 2 days a week early. Otherwise, you're going to be waiting 2 hours for your symptoms to get better. And then, again, it should only be used if less than 3 times a week. Opioids. Codeine at 30 to 60 milligrams or tramadol at 50 to 100 milligrams. Both these medications cause nausea and both these medications cause constipation. It's important to remember that tramadol may induce seizures. So you certainly don't want to use it in somebody that has a history of seizures. And tramadol is actually the only non-dopaminergic drug that has truly been associated with augmentation. Lastly, they talk about benzodiazepines, and these are probably especially useful in those patients that have underlying physiologic insomnia or a comorbid condition such as that. They do improve the sleep consolidation. However, the patient continues to have periodic limb movements at night. It really has no effect on that. And there are no controlled studies that demonstrate a benefit. So if we move on to chronic persistent RLS, and this is defined as being frequent enough to require daily treatment. Usually occurs on average at least twice a week and results in moderate or severe distress. And again, you have the non-pharmacologic treatment. You have your non-ergot dopamine agonists, or you can go ahead and use your alpha-2 gamma calcium channel ligands. And if we compare, which one would you choose out of these? I think you'd have to look at your patient. If the patient really has severe RLS, probably the dopaminergic agents are preferred. Additionally, remember I said that there was a higher suicide rate in the gabapentins group. So if they have comorbid depression or dysthymia, you may wish to use the dopamine group. And likewise, dopamine group does not tend to cause as much weight gain or obesity, so that would be preferred there. If you remember, these drugs are also used for chronic neuropathy, so if they have comorbid pain, the alpha-2 delta ligands are a better choice. Or if they have anxiety, dopamine is likely to worsen their anxiety. Comorbid insomnia, remember the biggest side effect these drugs had was making you tired. And lastly, if there's any history of DWIs, drug abuse, hypersexuality, Vegas vacations, you probably do not want to use dopamine. You'd probably be better off to start with the alpha-2s. The alpha-2s. And lastly, we're going to go to refractory RLS. So check iron stores and replenish if appropriate. Consider and correct all other possible exacerbating factors. And then you can consider combination therapy, where you use dopamine agonist and an alpha-2 gamma delta ligand, an opioid, and a benzodiazepine. Or you can actually consider high-dose opioid therapy. I just brought this here. There are other alternative methods out there, and this is one paper that was published in 2011 where they looked at near-infrared light treatment. And they had 34 volunteers with symptoms of RLS and randomly assigned them to a treatment or control group. And then for a 4-week period, the subject underwent 12 30-minute treatments to their lower legs with near-infrared light. After 4 weeks of treatment, the treatment group had a greater improvement to their restless leg syndromes than the control group. And that improvement persisted 4 weeks after the treatment had been completed. There's another published in Chest in 2009 about the use of pneumatic compression devices. 35 patients with one group wearing pneumatic compression devices and the other wearing a sham device. And, they were worn for at least 1 hour per day for 4 weeks. And the starting time of the day was typically, you wore it when at the time symptoms were usually going to begin. And the restless leg severity scores decreased from 14.1 to 8.4 in the pneumatic compression device group, with complete relief occurring in 1/3 of those wearing PCD and none in the sham group. So in summary, I think the biggest thing, if you have somebody with a restless leg, is remember, placebo is pretty effective. So start with just talking to the patient about it. Emphasize sleep hygiene, emphasize the behavioral modifications, treat any other comorbid condition that's affecting their sleep, i.e. obstructive sleep apnea, other disease processes. Look for diseases that may be actually the underlying etiology. Does this patient have renal insufficiency? Are they hyperthyroid? Do they have diabetes? Check iron stores with either ferritin, some people say transferrin, usually we use ferritin levels. And then make sure to review their medications. I can't overemphasize that because there are so many medications that will make restless leg syndrome worse. And then choose treatment medications wisely, thinking of the patient as a whole and not just the restless leg syndrome. Questions? Yes? I think that I don't think they're one and the same is the answer. But certainly there's at least 80% of restless leg syndrome patients will have periodic limb movement on a polysomnogram. However, restless leg syndrome is a disease of history. So even if you don't see periodic limb movements on a PSG, that doesn't mean they don't have restless leg. Yes? I don't think that we have good data on that. And you know, if you look at the retigotine studies, I think that's still debatable whether the retigotine people are going to, you know, I think there's still some question of whether they're going to have higher rates of augmentation too. But there is a hint, at least, that the longer acting medications may help decrease that rate of augmentation, because part of the augmentation is kind of like the Afrin nasal spray, is that rebound effect and the augmentation. Yes.
Is this on?
Yes.
I do a couple of comments. You know, Paul, this placebo thing is very, very interesting. Of course, in Latin, placebo means I shall please. And so a number of studies on placebo. Can you hear me in the past?
Yeah.
So now I was saying that in Latin, placebo means I shall please, which in these studies where patients are being followed by good-looking nurses and doctors and so on and so forth, and all other instructions that patients are given. But what is not realized, which is very important, is that studies have shown that placebo releases endorphins as well as some dopamine. For example, in the pain studies, when patients were on placebo and were given naloxone, pain came back. So use of placebo somehow is associated with the release of both dopamine and endorphins. And in restless leg syndrome studies, these two medications, as Dr. Raymond was talking about, are very effective in the treatment of RLS. So I just wanted to, but of course in clinical practice, we don't give placebo to patients. We just have to treat them. I just want to emphasize a couple of important points that there are now 4 or 5 studies that we have on PLM, which, as he mentioned, 80 to 90% of patients with RLS do have periodic lip movement on first and second night polysomnography. And these PLMs particularly those with arousals, are associated with autonomic nervous system activation. So there are now 4 or 5 studies in the Mr. Ross study. PLM was associated with incident hypertension, and in studies of heart failure, PLM was associated with increased mortality. So again, this may have to do with what you were talking about with the pulse rate and blood pressure going up in association with, particularly with those with the arousals. So the jury is out if the treatment of PLM in the context of cardiovascular disease will have any effect on mortality or not. But those are some of the important recent studies.